afternoon, everyone. I'd like to start by thanking the organizers for giving me an opportunity to present the work we do in our company here today. So my topic is going to be sort of slightly switching gears to some of the talks you've heard throughout the day, wherein the focus of this is where we use antibodies against cell cycle biomarkers and how we can use it for diagnostic applications. And our company, which is based in Cambridge, so we are currently in the process of developing the so-called cell cycle cancer test, and I think I'm hoping to convince you in the next 20 minutes or so as to how, as to why we think this is quite a powerful tool for breast cancer prognosis and for treatment decisions as well. Right. Again, for those of you who are not familiar with the subject, I just wanted to start off by giving a brief background on the replication initiation machinery. Now, the focus of the cell cycle cancer test that we've developed is based on about a combination of 3 cell cycle biomarkers, which are all involved in the process of DNA replication, which happens in the S phase of the cell cycle. Now, pretty sure most of you are familiar, the eukaryotic cell cycle is divided into different phases. The M phase, which is called the mitotic phase. You have the G1 phase, these are designated the gap phases in the cell cycle, and then you have the S phase, which is the synthetic phase, and then the G2 phase. Now, understandably, these entry into different phases of the cell cycle is tightly regulated by a whole myriad of proteins. To start with, I wanted to talk about 3 proteins in particular, a protein called as MCM. Now, the reason I'm choosing these proteins are because we've developed a cell cycle algorithm based on these 3 proteins. So we have a protein called as MCM, which is a mini chromosome maintenance complex. It helps in the initiation of replication. So it basically licenses the cell to replicate. And then you have a negative regulator of replication, which is called as geminin. So basically, whenever the cell needs to stop replicating, this is when it starts to kick in, and it's expressed mainly in the SG2M phase. The importance of MCM is that it's present throughout the cell cycle. And another protein that we're interested in, which is specific for the M phase of the cell cycle, is a protein called as histone H3. Now, it's a phosphorylated version of the histone H3 protein, which gets phosphorylated when the cell enters the M phase, and it gets rapidly dephosphorylated before entry into the G1 phase of the cell cycle. Now, I think from the sort of context of eukaryotic cell biology, it's important to understand there are 3 key ways a cell can decide to go out of cycle, if you like. So you have something called as the differentiated state, which is quite common for something like the liver cells, or here we can see the colonic crypt cells. And you can have the cells move into something called as the senescent state, which is like an irreversible state where the cells can't really get into cell cycle anymore. This is like it's designated as the G0 phase. And you have something called as the quiescent state, where it's reversible, as shown in this arrow here. So the cells they're delayed, they're arrested, but they, if they get the appropriate priming signal, they can restart and kick back into the cell cycle, if you like. Now, so what is my talk going to deal with? So I will be talking to you about how DNA replication and initiation proteins play a very important role in tissue maintenance and cancer. And the model of cancer that I've chosen for today is breast cancer, and I'll detail as to why we've used this as the model. And also give you an indication of, now this is a bit of a cliche, but what I'm trying to show here is basically how, what the work that was done in a university laboratory, how we are sort of, at the company trying to develop this as a test for breast cancer detection and prognosis. Now, this test has been mainly validated for breast cancer, but there are applications from groups worldwide independent to us showing that, the same algorithm can be applied for lung cancer, glioblastoma, and quite recently, less than a month ago, from UCL in London, where they've shown this that this particular test has utility for leukemia as well, so just not solid-state cancers. Now, there remains a huge clinical unmet need. Now, obviously, we have to have a very important clinical unmet need when you're trying to develop a test. Now, there are, most of you might be familiar, especially when it comes to breast cancer diagnosis and prognosis, there are lots of companies making some very advanced progresses, and I think there are lots of movement towards genomic sequencing, genomic technologies, but also your mainstream tests based on immunohistochemistry gains a lot of importance. Now, what I want to mention in this particular slide is that there is still a huge unmet need in breast cancer, because the tests that are out there today, they don't have a lot of discriminative utility, and also, they don't really fulfill the function of the so-called precision medicine or the personalized medicine, which is one way where quite a lot of cancers are trying to get into, because what you don't want to do is try and use the approach of one size fits for all. Instead, you want to go with actually, is the patient likely to respond to chemotherapy or not? Or, for example, is he or she harboring a particular mutation? And if so, can we give him this drug to treat that particular disease? So that's the kind of approach that especially mainstream cancer therapy is trying to get into. And we're still in the initial sort of stages there, but hopefully once our test gets commercialized, that's the hope at least. We also we would quite nicely fulfill the precision medicine criteria there. Right. Now, what is the requirement? I'd like to spell out the clinical unmet need a little more here with breast cancer. Now, what's the requirement? Basically, about half of the patients who receive treatment, either in the form of chemotherapy or traditional chemotherapy or radiotherapy, will never relapse, whereas the remaining half will die of metastatic disease. So, which is shown in the black hemisphere there. Additionally, there are a third of the patients in breast cancer where there's no sort of involvement of lymph nodes, who will still experience relapse. Now, this is very important because, you sort of, if there is no lymph node involvement, usually they're considered sort of, good prognosis, but that's not necessarily always the case. And then we also have 1/3 of node-positive patients who will be receiving adjuvant therapy, not receiving adjuvant therapy, but will be disease-free. Just trying to see where who will be disease-free after about 10 years. So this is an important measure for us, because all the tests that you're trying to develop, you sort of, as and when there is clinical outcome data available, you try and match it with your clinical outcome data. So a third of the node-positive patients who don't receive any adjuvant therapy will remain disease-free. Now, so this slide is just a summary slide to tell you about the immunohistochemistry based test that we've developed. Now, at Fahy Laboratories, which is our company, we have developed our own antibodies against the biomarkers in question here, which is MCM, which I already spoke to you about, and we've used another biomarker called as geminin. Sorry, I'm just trying to figure out. Yeah. Yeah. So I think the battery's probably. Yeah, there you go. That's better. Thanks. So we're using MCM, and so I just wanted to show you some immunohistochemistry images of what MCM staining looks like. It is pretty dark, intense staining, and it's expressed throughout the cell cycle. And the other biomarker of question is geminin protein, which just to refresh your memory, it's expressed only in the S, G2, and M phase of the cell cycle. And the third biomarker in question is this protein called as H3, which gets phosphorylated when the cell enters the M phase and gets dephosphorylated towards the exit of So these are the three. So we've developed a multiparameter based test. Now MCMs, they're used quite widely for prognosis and for treatment prediction of cancers. Now, so it's not so unique in the sense, so our USP comes in the fact that we've developed a multiparameter assay based just on MCMs, geminin, and H3, phosphorylated H3. And I think I will try and show you wherein, our multiparameter assay has a lot of utility compared to just using single biomarkers. Right. So what do we do? So as I've said, this is an immunohistochemistry-based test. So we get tumor biopsy material in the form of formalin-fixed paraffin-embedded tissue, which is usually the tissue we get. And we subject the tissue to multiparameter analysis using sort of a two-stage approach, if you like. So in one of the first stages, we look at a protein called MCM2. Now, there is a reason for doing this because, as I've said, MCM is ubiquitously expressed, and it is absent in very few conditions, especially when the cell is in an arrested state, if you like. So if it does not have any MCM expression, which in this case is shown as no brown staining, then what you do is you go and subject the same sample to another biomarker test, which is geminin or H3. And in fact, actually, just to be sure, we do geminin and H3. And if we don't see any signal for these proteins using our antibodies, then we can safely classify this patient population as phenotype 1. So that's what we call them. We call them class 1 or phenotype 1. And we've shown with clinical outcome data, which I'll come back to in a couple of slides, that the patients who belong to this particular class are good prognosis patients. So they have a disease-free survival of sort of, greater than 5 years, and it's very, very helpful. So this sort of classification. Now, another sort of, class that our test quite uniquely identifies, which is not identifiable using the current clinical tests. So currently, whatever tests the breast cancer clinicians, the oncologists are using, are failing to identify this particular class. And these particular class of patients are very, very important for relapse monitoring. And I'll explain this class 2. Now, you can have a scenario where a set of patients are, they have MCM proteins expressed, but when you then do the other biomarker analysis, geminin and H3, I'm sorry, it says or, we usually do geminin and H3, and you see no expression there, then we classify these patients as class 2 patients, and they are still good prognosis patients. Now, these are good prognosis patients because their tumors are in a delayed state, they're in an arrested state. Now, it doesn't need to show they won't kickstart their replication machinery and become actively proliferating, but at the point of diagnosis, they're good prognosis patients. Now, it is this class of patients that the current clinical tests are failing to identify. So I think that's why we think ours is a very nice, our test is a very, very useful patient stratification tool. And then you have the common scenario, of course, where you have the biomarker expression. When we use our own antibodies against MCM, you get high expression. And when you also look at expression of geminin and H3, you get a positive signal there as well. And we do know that, because these 3 biomarkers at different stages of the cell cycle are expressed, the cell is actively cycling and it's proliferating, and it does correlate with quite poor prognosis. Now, so, sorry, before I go to that slide, I just wanted to... So one thing we can say about this particular test is, as I've said, it helps in identifying class 2 patients or phenotype 2 patients, which usually the current clinical tests fail to identify. And also, another reason why we've chosen breast cancer model to try and validate the cell cycle algorithm is most of the chemotherapy treatment that's used for breast cancer is all based on cell cycle chemotherapy agents. Agents like vinblastine, agents like paclitaxel, etc. So let's look at a scenario where quite a lot of chemotherapy is given to patients belonging to this particular class, and you're giving agents that belong to the S phase, the G2 phase, or the M phase. The cell cycle targets are not going to be expressed in this particular class, which is your phenotype 2, so they're not going to respond to chemotherapy. So A, you're saving them from treatment-related morbidities, and B, you're basically saving a lot of money. So what's the point in giving treatment to a particular class of patients where it's not going to work? Right, so that's the sort of element of predictive biomarker analysis that we're trying to carry out, wherein we think it also helps us. For example, we think if we keep a close watch on this on patients who belong to this particular class, it'll also help us in relapse monitoring, if you like. Now, let's say you conduct another test on a yearly basis, and the patient has the same immunohistochemistry signal, with MCM2, geminin, and H3, we can quite safely tell the clinician that the patient is still good prognosis. But let's say the tumor switches to this profile, then we can advise the clinician, or our test can tell the clinician that, immediately you have to start up with aggressive chemotherapy. Right. And now, the power of the test is that, we were fortunate enough that we had clinical outcome data for all the patients we've analyzed in this particular study. We have about 200 odd cases which we've done, and we've also carried out additional independent validation in another 250 cases. And in all cases, what we could very convincingly show is that patients who belong to phenotype 3, which is shown in green here, have an increased rate of relapse. So using your typical Kaplan-Meier survival curves, whereas patients who belong to phenotypes 1 and 2, they're basically good prognosis patients who belong to groups 1 and 2. So I think we can quite convincingly say that it's the cell cycle phenotype state which does indeed predict the outcome of breast cancer after surgery. Right. Now, so what have we done basically in terms of, I just wanted to walk you through the process of how we've done our own antibody production and validation. Now, these antibodies are available commercially. They're quite bog standard antibodies, but the antibodies we've developed, fortunately, I think I'm not going to go through all the data with you, but at least for MCM2 and geminin, the antibodies we've developed, we think, are better than your traditional gold standard antibodies that are available out there. And we're talking here about in vitro grade antibodies. I'm not talking just research use only antibodies. So we, obviously being an IVD company, we do all this in the guidelines of the ISO 13485. Now, I don't have to go through this, but I just want to start off with, we've used a CRO to help us with the immunization and the clone generation, where clone preselection happens by ELISA. And this is when clones are transferred to our facility in Cambridge, and we start off with looking at isotype homogeneity, and then we do a whole series of tests. I give you some examples of what we've done in terms of IHC titration and reproducibility, and at every stage we ensure that we compare our antibody clones with the gold standard antibodies. We pick at least 2 gold standard antibodies to try and compare our data to. And then we do so-called accelerated antibody stability data, and then we push it and move it into development. And in this case, I'm just showing you an example of MCM antibodies. Right, in the late stages of development, what we do is, we do so-called IHC titration curves against, basically we try and dilute our antibody. We do a serial dilution, and because if it follows the principles of sensitivity, then you have to see a reduction in your signal, which is what we see in this case. And that's just to show you the signal that we get out of a positive commercial antibody for MCM2 from Becton Dickinson. So that's your titration curve. And then also what we do as a part of the validation of these antibodies is we try and do immunohistochemistry characterization in tissues with varying expression levels. So we cherry pick based on Human Protein Atlas website or other websites, or using our own literature. We do an extensive literature search to try and pick for tissues where you can see high expression of your protein of interest, medium expression, and low expression. So that's sort of, so these are certain FDA guidelines one has to follow because before you can qualify a particular antibody as an IVD grade antibody. And last but not least, what's very, very important for us is the stability testing of antibody clones. And in this, I've cherry-picked an example where we do accelerated testing analysis. We select clones. Our minimum benchmark is 18 months equivalent stability in real time. So this shows data set of an antibody clone that's stable at 37 degrees. After 80 days, it's been subjected to this particular test. So, right. Now, switching back to the actual test in itself, what we've also done is we have independently, looked at a clinical trial that was conducted in London. For confidentiality reasons, I can't tell you which hospital we've gone to, but it's not going to be very difficult to guess, where we have basically shown that we retrospectively went back to these trials. We had access, we had ethical permission, and we had access to the tissue blocks, and we subjected these tissue samples to, the tumor tissue samples to our cell cycle algorithm, if you like. And what we have seen was that there is significant over and under treatment for patients with breast cancer. So, if you look at phenotype 1, there were about 24% of patients who received adjuvant chemotherapy with minimal benefit. And we can say that this was with minimal benefit because, their disease-free survival was pretty good, and they still sort of, at least till when the data was collected, they were fine. There was no risk of relapse in these particular class of patients. So what we are trying to say is, look, just using the bog standard clinical criteria, you still have 24% of patients who've received chemotherapy with no benefit at all. And the same data is pretty much valid for phenotype 2 patients as well in the data set that we've collected. So again, here, the patients don't respond well to chemotherapy. Now, it's quite simple because biologically speaking, if a drug target is not expressed, why should the cell respond to chemotherapy? Now, what's interesting and what's more worrying is the phenotype 3. So there is about a staggering 46% of patients who did not receive treatment with adjuvant chemotherapy who, technically speaking, should be receiving the chemotherapy because, they almost certainly would have benefited if they did receive the chemotherapy. But using the standard clinical criteria that's available out there, the current tests fail to identify this. And, I think I can say with a lot of confidence, at least in this particular clinical trial, our test has identified patients, that should be receiving chemotherapy treatment, but they have not received this particular treatment. So this is under treatment, if you like, for patients with breast cancer. Now, what are the implications of our particular test? Now, obviously, we are in discussions with various companies. We're looking at sort of, licensing and partnering opportunities. And as I've said, pointed out earlier in my talk, we have basically indications that this test is quite widely applicable for lung cancer, for glioblastoma multiforme, and other forms of cancer as well. So, which was quite which sort of, improved our confidence levels quite a bit. Now, another huge sort of, potential and clinical application that we are targeting, and this is something we are working towards right now, is looking at oncology clinical trials and oncology drug trials. Now, I'm pretty certain all of you are familiar that the success rate with oncology trials, especially involving chemotherapeutic agents, cell cycle phase specific chemotherapy agents, is quite poor. It's less than 1%, the success rate. Now, we think, our test could try and sort of, improve those success rates for the future. We also, the reason why I say this is because I think the patients or the people who are being targeted to these clinical trials, their cell cycle phenotype is not being determined. Now, let's say you recruit patient populations who belong to phenotypes 1 and phenotypes 2. They're not likely to respond to chemotherapy. So if you subject them to a chemotherapeutic drug, the response is going to be pretty poor, and that could very well result in a failed clinical trial. So we actually think we could go back to some of these big pharma companies and look at their failed drugs, especially against cell cycle phase specific agents, and try and get some more informed and hopefully better data out of their clinical trials. Now, additionally speaking, also what we want to do in prospective trials is we want to use this particular test to identify patients who are going to be sitting in either the phenotype 1 category, if you like, the phenotype 2, or the phenotypes 3 category. So again, this is a very, very, very useful test. This is going to be like a useful companion diagnostic test, if you like, in trying to identify, stratify patients accordingly for use in clinical trials. And this is going to give the regulatory bodies and the regulatory authorities quite a lot of confidence, because, again, to the best of our knowledge, there are not very many tests out there that can do this kind of stratification, because what you want to do is you want to try and use a particular drug on a patient only if he or she is likely to respond to it. And I think our test can second guess that. Right. Just to summarize, I think the USP, the advantages that we think our test addresses that not very many tests that are out there, and some of them even in the market that can't do is. So our test can be used for all forms of breast cancer. It can be used for something called as a pre-invasive ductal carcinoma in situ, and for invasive breast cancer, and it can be used against all molecular subtypes as well. So it's not really specific against HER2 positive breast cancer patients or HER2 negative patients, etc. Now, I think I've demonstrated, hopefully I've demonstrated well that it's a simple, inexpensive immunohistochemistry-based test. And we are going through the the health economics and other questions right now, but we think our test can be, for an equivalent test that's out there, which is like a genomic test, it's about a fifth or a sixth cheaper compared to that test. So it's now obviously it's an algorithm based on 3 different biomarkers, and you get a readout, and based on the readout that we get. Now, what I haven't, for want of time, I didn't really go through into that kind of detail. What we've also developed in our company is, I just wanted to qualify this a little better. What we've also done is we have invested in trying to develop an algorithm to do automated image analysis, because initially, when the tests were developed, it was all done by manual counting. Now, obviously, manual counting brings a lot of problems with it. So we have validated it using automated image analyzers and digital algorithms, and we could quite confidently replicate and reproduce the results that were a part of the original research study. Now, the other thing is, our test can identify chemotherapy sensitive and insensitive populations in breast cancer. So we think phenotype 3 patients will be most sensitive to chemotherapy, and phenotypes 1 and 2 will be insensitive. And also, it enables patient stratification for clinical oncology trials. Now, it's a big buzzword in oncology, that we need stratification tools to try and identify patients so that you can improve the success rate of clinical oncology trials. And lastly, more importantly, last but not the least, the standard samples that's available out there for cancer prognosis, diagnosis, etc., is formalin-fixed paraffin-emitted tissues, and our test, could very well. In fact, actually, it is designed to work on FFPE samples. Now, the reason why I say this is important is because you have some genomic tests that are out there, wherein, for example, if formalin cross-linking is known to interfere with the readouts that you get when you do DNA analysis, RNA analysis. Now, I think we have an advantage there. Right, and I think that's pretty much it, and I'm happy to take any questions with regards to the talk.
Questions?
Any questions?
Yes.
Yeah.
Yeah, I was not entirely clear about that group of patients that were not treated by adjuvant
Yeah.
chemotherapies and never got the cancer back in return.
So a third of the
They
patients.
had cancer then apparently.
Yeah.
So how were they cured?
So you're asking about the group that basically did not relapse, you mean?
They didn't relapse.
Yeah.
And they didn't receive adjuvant chemotherapy.
Adjuvant chemotherapy.
What did make them, what cured them?
Well, it's we're not really talking cure there. At least their disease was stable. You know, they were sort of considered to be
Well, it says they never came back.
Yeah. So well, that's the it's a good question, but unfortunately I don't really have an answer to it as to why their disease did not relapse, because
So you didn't make that decision. That was
no, that was the clinician. Yeah.
But what I'm asking is, what kind of therapy did they get as an alternative to the adjuvant chemotherapy?
Well, let's say, yeah, so I think I can answer that question quite well. Let's say they belonged to, some of those patients I do know that, they belong to the HER2 class. So they got, they got the HER2 antagonists, trastuzumab, etc. Yeah.
So it is important to have this distinction between hormone receptor types, HER2 types.
Yes, certainly. But the beauty of our test is it sort of, it doesn't discriminate between across various subtypes.
I understand now.
Yeah, that's all right. Any other questions?
I have one.
Yeah.
Say, at least for some of the permutations of your positive and negative assessment and prognosis.
Yeah.
What about, people are talking about exosomes as being secreted little vesicles with parental markers. So from peripheral blood, could you, maybe if you get a baseline, could you use your markers in a peripheral blood type assay? Is that possible?
That's a perfect question. In fact, that's what's, I think, that's what's been done for AML, for leukemia, actually. So that, wherein they've used it on a limited data set now. It was only an N of, 30, if I remember right, from this. Yes, the same cell cycle biomarkers, the same cell cycle. So this was a paper that was published about a couple of months ago. So they've used that for peripheral sort of, but, in order to gain confidence, we need to sort of validate that quite robustly. But it was just an idea, actually.
You couldn't with exosomes. You could. Well, maybe you could if you use other markers in the exosomes. You could get a ratio of the absence.
Yes. Yeah. Because you're right. It's not with these markers and with the biomarker expression that we're looking at against using our antibodies. We're not saying it's like a black and white signal. It's the percentage expression, if you like. So that's important.
So anyway, the audience isn't familiar. Exosomes are secreted little liposomes, like little vesicles that they're finding most cells shed, and they're doing more and more work with the vesicle then representing, this exosome representing the milieu of surface markers or even other markers within that particular cell. So if you can find this in the peripheral blood, if you can get a ratio of the positive signal to something else, then maybe